Good evening, friends and colleagues. So basically, this is valvular heart disease section, and I'm here to um, I'm here to talk in favor of TAVR, which is a better strategy for a clinical scenario which is given. So this is what all has been given to us as a 65-year-old female. She has effort angina NYHA class 3. She has a history of syncope twice. Transthoracic echo shows gradients of so the clinical scenario is 65-year-old female, NYHA class 3, history of syncope twice, transthoracic gradients of 112 by 66 millimeters of mercury. There's normal coronary anatomy, STS score of around 3, and CT scan shows suitable lower limb and valve CT findings. Ascending aorta, abdominal aorta arc are all fine, and LCA height is around 13 millimeters. So if you see this, then this is a typical case of symptomatic severe low risk aortic stenosis, meaning by if the patient is for surgery also, this would be a low risk surgery. Now the advantages of TAVR over surgical aortic valve replacement, for which the patients as well as physicians are attracted towards this, is that you don't need to open the chest, can be done from groin in most of the cases. You do not need cardiopulmonary bypass, can be done under local anesthesia, early mobilization, early discharge, and resumption to routine activities. Now, first, since it is low risk, we need to understand the evidence for TAVR versus SAVR. So this all started with high-risk patients and inoperable patients. So it was partner cohort B and then cohort A, which was for inoperable as well as high-risk patients for aortic stenosis for a balloon expandable technology, and it proved that it works well and it is superior to surgical aortic valve implantation. And then the similar thing was done for self-expanding technology with core valve prohibitive risk and core valve high risk, in which they documented similar findings. So the stage was set in for TAVR for high risk and inoperable patients, and then it went to intermediate risk with partner 2 trial and core valve intermediate risk trial, again proving the superiority of TAVR versus SAVR at 1 year all cause mortality. And then came the low risk trial, the trials which are the foundation of evidence for this patients, which we are going to discuss, partner 3 trial and core valve low risk trial. And in both these trials, the partner 3 is a trial for a balloon expandable valve. It says that in severe aortic stenosis with low surgical risk, the rate of composite of death, stroke, and rehospitalization at 1 year was significantly lower with TAVR than surgery. And for core valve low risk trial, it again, the patients with low surgical risk, TAVR with self-expanding supraannular bioprocesses was non-inferior to surgery with respect to composite endpoint of death and disabling stroke at 24 months. Now, where do the guidelines stand? This is the chart for the patients who need to be treated with severe AS. But in general, I would like to focus on one thing. This is for high risk and prohibitive risk. It is completely in favor of TAVR. For low risk and intermediate risk, the cutoff point would be, I won't go into detail of this whole chart, but in general, the cutoff would be 65 years. Less than 65 years surgery, 65 to 80 years SAVR and TAVR class 1, and more than 80 years TF TAVI is class 1, while surgery is class 2A. What is the evidence for ESC guidelines? I think cutoff becomes less than 75. So 65 and 75 for American and European guidelines. Now, so this patient was a low risk patient, and this patient also, since we have evidence with both the trials, partner 3 trial as well as the core valve low risk trial, this patient would probably qualify for TAVR, and the guidelines would also support that. At least the American guidelines would support that. But when we are dealing with these low risk patients, there are few things which we need to understand. There are 2 things. One is the procedural success. So when you see a CT scan, you need to assess by CT scan, what are the chances of annulus injury, what are the chances of PVL, what are the chances of complete heart block, what are the chances of mortality, and what are the chances of coronary occlusion or need of chimney or sulcal stand during the procedure. Meaning that if there is anything which predisposes the patient to complication, which makes the TAVR high risk, in that scenario probably we need to hold ourselves, and then probably it would be more for surgery. So the aim is to give results equivalent to SAVR. So this is one thing. And second thing is late issues. The late issues are, what are the late issues? Late issues are the durability of the transcatheter heart valve. So once you do a transcatheter heart valve in young patients, we know that it should last as long as possible. So the durability of transcatheter heart valve becomes very important, and it has to be compared with the surgical bioprosthetic valves. Second is, if this patient gets a myocardial infarction, whether you would be able to hook the coronaries or no. That deals with coronary access after TAVR. Of course, when you do a surgical implantation, you cut the native valve and implant the surgical valve exactly in a similar fashion, so commissures are aligned to the coronaries. I mean, the hooking is never a problem, while TAVR valves in general are not so. So initially they were deployed in a manner in which they would be commissurally non-aligned. So in those cases, and can you be a bit more silent? Thank you. So in those cases, I mean, we would have techniques for commissural alignment, which is possible for that would be. So the techniques for commissural alignment should be practiced during TAVR. And what happens when this patient gets TAVR in future? So in those cases, again, you need to understand the risk of coronary occlusion during the procedure and possibility of accessing the coronaries after the procedure, which would be determined by the risk of plane, depth of the THV implantation, and commissural alignment. So if you look for the durability of the TAVR valves, this is the comparison, which is a 8-year follow-up. Routinely, the mean time from the deployment of a surgical valve to a redo surgery is 8 years, as per early surgical data. And so Notion trial at 8 years, you would find that the surgical valves, I mean, the TAVR, I would read the conclusion in this. I mean, there are no significant differences in the risk for all-cause mortality, stroke, or myocardial infarction, as well as the risk of bioprosthetic heart valve failure. However, if you see this slide, the middle one, the mean gradients are still better with transcatheter heart valves, and the effective orifice area is also better with the transcatheter heart valves. So they do as well as surgical aortic valves. So that point is also justified. And I would now go to the idea of the risk plane. So you could see these are different valves: balloon expandable valves, lotus valve, and other valves. And the point to which the leaflets raise are the risk plane, because once you put another valve inside this, the leaflets are going to rise up to the top of the commissure. So a balloon expandable valve has a slightly smaller risk plane. So if your coronary ostia is above the level of the valve frame, it is type 1, and you could easily access the coronaries even after TAVR procedure. While if it is 2A, meaning that the risk plane is higher and the coronaries are lower, then you would need some space in between the valve frame and the aortic wall to hook the coronaries, which would be called as VTA if you are going to hook it outside the valve frame, or you can go inside the frame and try to hook it. So the type 2B is where there is very little space in between the frame and the aortic valve. So these are the three types, and if you think type 1, if you put another valve in this where the coronaries are higher up, then it should not be a problem. Type 2A, there is some space, it is still feasible. Type 2B, since you are going to deploy a valve and VTA is very low, there would be a ceiling at this level. So the blood is not going to flow from the ascending aorta into the sinuses. The process is called as sinus sequestration, and there is a chance of coronary occlusion. So this type 2B patients sort of valves and they are being simulated. So how do you go about it? So this is how you measure the VTC distance. This is the frame, and this would be VTC if it is at lower level, and VT-STJ if at the top is at the top of the frame. So in general, if the patient is less than 55, the consensus is it goes for SAVR with mechanical wire prosthesis. 65, 55 to 65 is a gray area. 65 to 80, you simulate CT scan, calculate VTC and VT-STJ. If it is more than 4 and 2, you are good for first TAVR. And if the risk plane is below the level of STJ and or the VT-STJ is more than 2, you are fit for TAVR and TAVR for the future also. So then you go for TAVR with balloon expandable or self-expanding valve. But remember, balloon expanding valve has an advantage that it has a smaller frame, so it would be maybe better. And self-expanding valve, you would also need commissural alignment. Now, if CT simulation shows that VTC distance is less than 4 and your VT-STJ is less than 2, you might have challenge in the first TAVR also. At the same time, you might have a difficult time during second TAVR. So then it's best to do SAVR during the first wire prosthesis. The idea is when you get a CT scan for the first time, you should have a clear impression that you would be able to do TAVR and TAVR in this procedure in patient, at least on your analysis for the next time. So, and if the patient gets transcatheter heart valve degeneration, then what are the ways? This is, for TAV and TAV, you have to calculate VT-STJ, and if it is more than 2, you are fine with it. If it is less, either you surgically explant or you are looking for basilica or some sort of leaflet modification, or chimney would be only possible if you are above the level of risk plane. So I would say, since it was being told that the anatomy of the valve is suitable, I believe that whatever I have discussed fits into this, and this patient is for that. But if it doesn't fit, which might be possible in 15 to 20% of patients, then probably this would be better treated with surgery. I rest my argument here. Thank you.
So thank you very much, Kamal Bhai and his team, for having me here. Thank you, Manik Bhai, for agreeing to be fellow debater. Though there is no debate, we have agreed on most of the things, and we are going to agree. I'm going to kind of extrapolate or kind of reinforce the same things that you have said. We can look at this topic from two perspectives. One, what we should do, and second, as you were mentioning about coronaries and stuff, how we go about it. So the second point is moot. Some expert operator like you is not going to face any challenge in this case, which is an old 65-year-old lady, good coronaries, good anatomy. It's a moot point. Technically speaking, if we can do TAVI or not. Data wise and logistics wise, whether we should do TAVI or SAVR, probably we can debate, and that's what I intend to do. TAVI is quite realistic, it's promising, it's here to stay. It's like how PAMI came into being, primary reinterventions, a few years ago, and it has really, it's a big boon. Today, so many hearts, so many ventricles are being saved by PAMI. The same way, it's going to be a life changer, game changer. But I believe it's still not ready for the young and the low risk patients. Why? Because there are some unresolved issues with TAVI as yet. Leaks, we'll go one by one. So one more thing we have to keep it in mind is that all the trials that we talk about are Western data where the average population is older. So if we were to extrapolate into Indian population, we would say if they are saying 85 octogenarians, we are going to say 75 or 70, but it's not going to cut it below, kind of. It's not going to, their 80 is not going to become our 50, right? This is just a symbolic slide where it's a review of 11 meta-analysis of 11 articles. Different studies, and some are clear-cut indications for TAVI, some are clear-cut indications for SAVR, and then there are some gray areas. One important factor about TAVI is paravalvular leak. If you go in SIR-TAVI, the leaks are very high. The leak rate is very high compared to SAVR. And it keeps on it remains. Many surgical leaks, because of the partial removal of calcium or be it as may, they tend to regress much more from what you see early on, tower leaks usually remain. And why this is important is because the mortality is directly related to this paravalvular leaks. And the mortality keeps on increasing. At the end of 2 years, the difference between the mild leaks and severe leaks is staggering. It also affects the LV remodeling, which is the purpose of operating, which is the indicator of how good the surgery is or how good the gradients have come down. And if you see, the LV mass regression is quite high when you put a surgical valve compared to a TAVI valve, especially when they have the leak. Second is, of course, the implantation of permanent pacemaker, conduction defects. It is assumed that serious AV block happens in 1 in 6 TAVI patients. Surgically speaking, because we are going to be operating directly under vision, it is very rare. In these days we hardly see the heart blocks. If I kind of rush it through, as per this 2020 article, the PPI permanent pacemaker implantation was 14% in TAVR versus 5.6% in surgical valves. Delayed high-grade AV block is an underappreciated complication of TAVI. This is another 2019 article. So there are a lot of patients who get heart blocks or which are unrecognized or they are recognized later. And again, as we said, the heart function and the remodeling both will be affected by this. Again, this is a Sweden Heart General Registry 2021 finding that risk of PPI should be an important consideration in the modern age, especially in transcatheter operations, especially in younger patients, and especially who are lower surgical risk, which is probably our patient. Again, CVA is also very underreported as far as TAVI is concerned. There are a lot of articles where the cognitive dysfunction post TAVI was quite high in rate of cognitive dysfunction was quite high after TAVI, which is and silent infarcts as well, which are kind of taken into the stride that they'll recover, and they do, but some of them do end up having long-term sequel. And embolization of calcium is certainly a risk factor in TAVI. I think many of the operators, I'm sure Dr. Manik Bhai as well, would have started putting Sentinel now more and more for this, but then it is going to add to the cost. And without Sentinel, you are always going to be worried what will happen now to the patient. This is a slide. This is a case we had done, in Bangalore once, and this is the debris removed, debris which were captured by the Sentinel device. Now, these debris are not going to go into the circulation in a sour patient because we are going to wash them off. Aorta is anyway clamped. So it is very unlikely that this bad kind of shower is going to happen in a surgically operated patient. There are some neo complications that are happening with TAVI. Any new procedure is going to come up with new problems like annular rupture, device embolization, tamponade. But probably with time it's going to get better. Durability, as Manik Bhai mentioned, is a big issue. These valves are crimped. These are handled very they are crushed in a way, and they are put in a patient who is already having calcified native leaflets in situ. So they are also going to impinge on the neo leaflets. So they are, sorry for this slide, this is just a photograph, I could not get the original one. But if you see on the left side is an intact neo leaflet, and on the right side is the crimped one. If you just look at it, you will realize that this is quite a trauma for the bioprosthetic valve. There are, of course, early TAVR failures with valve thrombosis, cusp ruptures, degenerations. These are accelerated because, as we discussed, the valves are crimped, the leaflets are crimped. So the TAVI valves tend to degenerate faster, and now we have better valves surgically, which are having 20 years, 25 years durability in vivo, and these have been introduced in Indian market about 2 years ago. This is called Inspiris valve, which has a better diameter, and it's going to last longer. Valve in valve remains the holy grail. We say that we'll be able to do it more often, but there will be problems with device malposition, obstructions, high gradients, PPMs. So universal applicability is also a problem with TAVI. Expert operators like you are not going to have, but TAVI is not something, it's got a steep learning curve. Not everybody is going to do it, and younger or inexperienced people doing it are going to have more problems. They are going to need 2 devices, they are going to need more coronary interventions, and then it's going to add to the cost, and of course it's going to be harmful to the patient. And last problem, of course, is the cost. I am going to do 4 showers in a cost of 1 TAVI. So with the best valve available today. So it's also going to be very, very important factor. As far as surgeries are concerned, I'm going to do minimal invasive surgery. We may even do a sutureless aortic valve, which I will just show you in a minute. So this is the my approach to the surgery. I can do conventional, but in this case, I can easily do the right anterior thoracotomy. This will be the scar for this lady, about 4 to 5 centimeters. She is not going to, the violation to the pericardial cavity or the chest, as we call, is not going to happen. If she needs another surgery, her sternum is virgin, her pericardium and her left ventricle is going to remain virgin. There are going to be no additions there. There is, it's just going to be like doing a virgin surgery again. Say we have to go in again after 5 years, 10 years, 15 years down the line for any reason. If you really compare apple to apples, we can even do a sutureless surgical valve, maybe not in this case, but a little interim or high risk case where we are going to implant something called this is what we had done about, say, month and a half ago at SAL. This is a Percival valve, which is a sutureless valve. We just need a rapid deployment. We just need 3 sutures for this. Just like a TAVI, we put the patient on bypass, we open the aorta, we implant this, and this will be a 1 or 2 size bigger valve because it is sutureless, a stentless valve, and we just come out without a problem. There are a few trials which again say the same thing. PPI implantation rates are higher. This is again a very old trial, but 5-year outcomes of the same trial were quite similar. PPI implantation was staggeringly high, and of course paravalvular leaks. Partner 3 again had what we surgeons call convenient route, that they said that a few things were non-inferior. So when you say, it's like telling a patient that हम तो ये बोल रहे हैं but फिर आप देख लो. So it's something like that. Again, partner had some limitations. The endpoints were not blinded. It excluded some patients where SAVR performs certainly better, like bicuspid or poor access. A lot of patients were lost or withdrew from the trial in partner 3, and a lot of patients were lost to follow up. So we still don't know why. And there is something called asymptomatic valve thrombosis, which we feel that it can be secondary to crimping, was not examined in this. So I would say that currently robust data for the durability of TAVI are only for 5 years. SAVR, of course, we have very, very long-term data. It is a prudent course based on the published evidence to recommend SAVR for anybody who is 65 or older and lower risk, which is our patient. So I would still say that I would do a minimal invasive right thoracotomy surgical valve replacement for this lady with the best valve available at 1/4 of the cost, and I think less similar risk as far as the mortality and stroke and atrial fibrillation or other things are concerned, and much lower risk of pacemaker implantation, paravalvular leaks and other neo complications. Thank you.